Thank you everyone for staying longer. This is the last panel of the day. Very long day. My name is Shadab. I work with the Union, International Union Against TB and Lung Disease as the head of partnerships. And I have a distinguished panel, really impressive panel to talk about something which is not generally talked about, but very important. We have seen this summit is about innovations. We had some 1400 registrations and we had a lot of delegates, 228 innovators, lot of posters, lot of discussion, lot of sessions, and everybody is talking about innovations. Innovations in diagnostics, treatment, AIs, other things. What we are going to talk about, innovations in multi-sectoral engagement. The topic is interesting and very needed in the context today. And to talk about this panel, everyone in this panel is coming with a background that they have demonstrated some innovation of value and meaningful innovations in their own respective fields in different sectors. So just to introduce panel quickly, because we have lesser time, I have additional resource person to my benefit, Rakesh there. I'll utilize you whenever possible because you are there. Dr. Jyoti Jaju, who is the director programs at the Union with bed throats and handling this entire program today. Uh, then Shibu Balakrishnan, he is from WHO India, another person who has mastered the partnerships, demonstrated partnerships in various formats, particularly public-private partnerships in health domain. Then Dr. Nishant Kumar, and not only communication, he also handles various strategic partnerships and demonstrated innovation in various areas. And CTD has actually done a lot of work. We have seen TB in a particular context, treatment, patient and doctor. But in last 1 decade, we have seen the program going from traditional route to various ministries, to corporate sector, to corporate hospitals, to NGOs, civil society, Lions International, Rotary, all you name it, Gram Panchayats. We have done lot of work of unconventional models. Thank you, sir, for being with us. And Dr. Upasana, she is the champion for us. She has been advocating for TB at various forums. She is at various forums. You name any business chamber, business forum, she'll be either heading it or she has been the head of that chamber. So this is again pleasure for us. And then Mr. Charudutta, I met him only this morning. Very impressive profile, lot of knowledge and work which he has done at grassroots level and policy level. So entire spectrum from a Gram Sabha to the PMO, he understands this canvas and how this can be utilized for the program benefit. And then very dear colleague, Dr. Sandeep Sharma, he represents IOCL. IOCL is a big name for the program. Not only they are the Fortune 500 company, they are the source of energy for all of us. They also have given, if I'm not wrong, the largest contribution of CSR in TB comes from them. So they have given n number of diagnostic tools, including health X-ray, for states, not for district, for various, and that's a huge number. I think around 700-800 machines they have given. Not only that, over a lack of workforce, he will do the correction, which is more than. They are doing awareness, screening and testing. What are those innovations? So this is the panel. I have a difficult job to do. And quickly I'll start somewhere to understand how each one of them have done this work. Maybe I'll just follow this sequence, But before that, I'll go to the Central TB Division, sir, to you, Dr. Nishant Kumar, because this is what we have been seeing. Traditionally, TB, a medical problem, from a medical problem, a medical approach to address this. This has now become everybody's business. Jan Andolan, Jan Bhagidari, ministries, civil society, TB champion, Nikshay Mitra, Gram Sabha, TB free Gram Panchayat, and then the amount of CSR which TB has attracted, and the projects and the private sector engagement, everything you have done 360 with huge success. So what is it that you have introduced in these years? What was the new and what innovative ideas you adopted? What was the change in the approach that we have got so much success? Sir, over to you. And every panelist has to have, generally 4 minutes. I have crossed 4 minutes, sorry.
So you have to give program a minute more. No, just kidding. So thank you, Shadab, for putting me in a spot. You are aware that I don't look after this component of multi-sector engagement, but I'm filling in for Bhavani. But then you have framed the questions in my favor. What I've been doing. So what you started that how what innovations in terms of engaging the private sector, civil society, ministries, and corporates. So I'll start with, it's not a new phenomenon. So innovation is something, it's very easy for other panels where you can show your diagnostic product or some AI or something, but innovations in multi-sector engagement is a slow process. But I'll start with the private sector because you started that initially it was a medical disease, but it always was a medico-social disease. It always was. But as Dr. Malik was saying, that every year we are adding 27 lakh new cases, 2.7 million new incidence cases. So, first I'll go to the private sector because if we take it as a medical disease and what we were not getting the support, so to say. So what we did there, so it's not a new thing, but then public private mix was very very well documented, very well identified component how to engage with them. So if you really see 2000 from 2015, where only barely a lakh notification came, to about 9 lakh which came in 23 and 24 consistently. It has taken a lot of hard work. So one is like the through the support of Global Fund, demonstrating that we have to bridge that gap through PPSA, and that showed us that innovation got us together, and then we are getting the results, implementing what was written on the earlier plans, actually implementing them. And now I'm glad to inform that these things were demonstrated through Global Fund support in terms of JEET, but now it has been taken up by domestic funding. So that's a real innovation in addressing the private sector. Second, you talked about involving the civil society. Again, it's a medico-social disease. The need was there. It was very well understood that it has to become a people's movement. But how? I mean, had we been talking about doing this 10 years back when we were missing about a million cases, 10 lakh cases, but 2018-19 onwards, when we closed that gap of missing million, and identifying, and through the prevalence survey, that fact coming to us that still the awareness about the TB is there's a huge gap. 64% of the people having classical symptoms don't seek care, they seek late. It has direct bearing on treatment outcomes, mortality, out of pocket expenditure. So so every component sort of complemented each other, and implementing what was actually written in the NSP when we implemented. So again, taking the partners along was one innovation. That don't work in silos, by for involving the community, use the TB survivors, build their capacity. So that was one innovation in engaging the civil society, and the response was phenomenal. When we trained the TB, we invested in the TB survivors by training them, building their capacities to raise their voice, show the facts to the program, and institutionalizing the participation of civil society in terms of TB forums. So that's how the civil society came on board. Private sector, I missed one thing, that the standards of TB care also contributed over the period of time. So now we are very, very meaningfully engaged with both the private sector and civil society. Now again, we all know the TB disease has it has multiple factors affecting it, which is beyond the control of health. So the talk, it's not that the discourse was not there, but now when we approach the ministries, and now the way we responded to COVID by whole of government's approach, and we have a case and example. This is also an airborne disease. This is a national emergency. It has much more mortality than compared to COVID. And experience of putting the TB infrastructure into COVID and getting the result out of it has given so it has given us a leverage when we talk to the ministries. This specific support we need from, we are very clear now that what we need from say defense, railways, they have their own hospitals, how to get the notification, so that closing the net of missing, closing the gap of missing point in cases. You talked about panchayats. So we have been talking, and in last 6 years, by continuously reducing the gap of the the incidents, which are getting into the net of the program, we reached out specifically from each ministry what we want, and the reciprocation was amazing. I mean, the 2-3 ministries I would like to point out. Ministry of Panchayati Raj, because in their mandate also Sankalp 2 says that Swasth Healthy Village, Swasth Gam Abhiyan, right? They also need. So if there is TB, it's not Swasth. Their goal is not. So we went in detail, get the extra funding in terms of awareness, in terms of getting the TB agenda into their GPDPs. Ministry of Tribal Affairs, again, it's a tough challenge to address TB in tribal areas, but then getting again extra funding from them, and then they aligning with our policies, and their state and district level functionaries regularly working with us. So we have MOUs with the 17 ministries, regular meeting. Of course, it all started with the political leadership, identifying and throwing that thought that whole of government's approach is required. So you talked about ministries, corporates. Again, we by the response of corporates, they want to add they want to contribute to this cause in India's fight against TB. They got on board, and then Pradhan Mantri TB Mukt Bharat Abhiyan was launched, that they can actually we made mechanisms so that they can actually support the TB patients in their area by their by contributing to their additional nutrition, and in a way it also put a positive spin on some effect on stigma associated with the disease, which was long there. When big corporates or a gram pradhan comes and distribute that. So multiple factors have multiple factors, you can call them innovation, but every component complementing each other got to us where what you talked about, uh, uh, truly engaging all the sectors. The topic is multi-sectoral engagement. So the gains which were made during by implementing the national strategic plan complemented, and everybody got on board. But short point is, multi-sectoral engagement is continuous discourse. That's what program has been able to do, and partners have supported us in that endeavor. So that has taken us where we are today. But we have challenges also, like CSR. Sometime it happens, it's just a one-time activity that we are working on. So yeah, so I covered private sector, I covered civil society, I covered ministries. Anything which I didn't cover, I would like to elaborate. Anything I missed, or did I stick to my time, or he short my time?
No, that's okay, but thank you for a detailed answer in a short time. I think the point which you made are very important, that people were very, very supportive. You approaching ministries, approaching corporates, they have been very forthcoming. This is something which we actually, all of us, came to know by doing this. That when you want to go with something which is good, and there are possibilities, like they want the TB problem is also a health problem, and it is everybody's problem, whether it is the workforce or it is a gram panchayat or panchayati raj. So we have seen a lot of success and a lot of what you are calling not so much new ideas, but at least new strategies were employed, and these strategies have given us a lot of success. Thank you, sir, for your response. Going forward, I think from this, now we can go into the minute details which each sector and each component has done. So I'll come to you, Dr. Jyoti. You had IDFI TB project, and a lot of innovations and new ideas were demonstrated under this project. One of these ideas is the corporate TB pledge, a initiative which is specifically designed with the corporate sector, tier based approach. Uh, how did we do this? What was the thought behind it? And how did we get what we get in terms of success? Your spokesperson.
Yeah, so I am basically dubbing for Dr. Jyoti because Dr. Jyoti is unable to speak. So Dr. Jyoti has given me the script, so I just need to
Okay.
tell Jyoti's words. But I will try to be as brief as possible. Even though you have said 5 minutes, I will speak in 1 minute. Corporate TV pledge, we all know it has been a uh, great initiative that has actually seen. It's one of the biggest innovations in mobilizing resources, engaging corporates, reaching the unreached, whatever way you look at. Because in India, if you look at the CSR funding, there is something called corporate social responsibility, and in that CSR funding in last financial year was around 30,000 CR INR. So in that one, if you look at how much they invest in health for the financial year 2023, it was 20%. They invested in health actually. And corporate TV pledge is basically the initiative which mobilized these companies, making them advocate with the companies, corporates, and making them invest right in their CSR initiatives. It's a part of their corporate social responsibility. So it has made, the corporate TV pledge has made TB, ending TB in the limelight, and advocated with the corporates to invest wisely, and so that each money they invested in is really their social responsibility. It has become a really social responsibility. It has added value to that. The coordination with the government machinery, the coordination with the partners among the corporates itself. Say, for example, one corporate partner with another corporate, benefiting the community. This is what the partnership has been really beneficial in. Lots of examples, lots of exercises which we won't be able to finish telling even in 5 minutes, but that is what Dr. Jyoti has asked me to tell. As of now, the corporate TB pledge has more than 400 corporates with more than $7 million mobilized alone through the corporate TV pledge. They have invested for in that way. That's a huge innovation that need to be fully documented, that need to be fully presented. Lots of learnings from that. I'll stop here, Shadab. I hope I have done justice. Thank you.
Thank you, Rakesh. So I think corporate sector certainly has huge potential, and what you are saying is just one project. Look at the possibility across country, and maybe if we get time, we will talk about how do we scale it in the next round. But thank you for your response. Now, Shibu, over to you, because we have talked about program perspective, we have talked about the corporate engagement, but the corporate hospitals, private hospitals, is a big player in the program in TB elimination efforts, because large section of society access private services, and you have demonstrated various models of partnerships for public health. Can you share with us Now when we are reaching 2025 and this event is about innovation and research, so I would be more interested to know, have we fully understood the potential of private sector and corporate hospitals, or there is still something which we are missing, and how do we best utilize this?
Yeah, thank you, Shadab. Wonderful question. So before I respond to your question, let me understand whether I understood your question correctly. You spoke about we and private. Okay, let me understand what is we. We means those who are sitting here, this entire TB community, and those beyond this. Whether do we, the technical experts, the program management experts, then I will include the community here among we, and I'll also include the political administrative leadership. The only person I will probably not include in that we is Madam Upasana Arora, because she is private. So do we have enough understanding about private? So collectively, my short answer is YES. Yes, we have good understanding. The political administrative leadership do understand about the corporate governance of the private sector, their revenue mechanisms, their adherence to regulations. That's very clear. The program leadership does understand the organizational behavior of the private sector. Then the technical leaders, they understand about how the protocols are there, the clinical protocols or other management protocols are there, the quality protocols. The technical people do understand that one. And when it comes to the staff of the public health care providers sector, the knowledge is rudimentary. Because still there are a lot of myths prevailing. The myths are like private. I ask these questions to people. What makes private private? The immediate answer is profit. Then I asked about, do you know about public making profit and private for non-profit? Okay, then it's confused. Okay, right. Then there is one thing more. I asked about why people go to private sector. Because they can afford. These are the myths still are public sector providers or staff do have. That's one thing. Then let us try to, the second keyword you asked me about private. Let us try to understand private. There are two kinds of private in India in our context. One is the health care facilities, that is providing care to patients. The next is health care facilitators, that is the NGOs and those who are providing other supports like specimen transportation, maybe advocacy. These are some healthcare facilitators do that, and India is wonderfully engaging them. But healthcare facilities, when you speak about those who are working there, providing diagnosis, providing treatment, are we engaging with them? Are we having partnership with them effectively? I still doubt. So if we ask me about what we know about the private sector, I now start differing with my own answer that yes, something we don't know. And what don't we don't know is something that 25 years ago, Sari Rudwadia and Mukund Blekar have published on the practices of the healthcare providers or the doctors in Mumbai on TB diagnosis and TB treatment. And it was like more than 100 different regimen for a single question on a new TB microscopically positive, microbiologically positive TB, 100 different regimen. After 10 years, they repeated that. And the title of the second publication was Nothing Changed After 10 Years. Okay. Then we need to have that kind of serial studies. This is some areas we do not understand. Then, in the private healthcare provider sector itself, it's pyramidal. Like you have the very highly specialized, super specialist and corporate hospitals. Then you have this primary care people who are the individual practitioners, family caregivers, and there are community practitioners like the informal care providers. That's a pyramid. Look at the notification that comes from. Probably Dr. Nishant will agree with me, this is an inverse pyramid. And we have very minimal number of notification from that level where most of the people first seek care from. And we have the highest number of notifications from the top of the pyramid, apex of the pyramid. What does that happen? That means that people have to traverse through that pyramid to reach there, adding delay to the diagnostic, the travel. So we still don't know about that. And we have many other things to understand, whether is it possible to have the private sector organized. We say private sector, but it is scattered. There is not organized, it's fragmented. So can we organize? I know that there are models where private sector was very well organized, and a person who has organized that is sitting here on this panel. Dr. Upasana is sitting here. So we know, but is it enough? Do we need to go more beyond this? That is the next thing. And probably we need to understand, can there be a accountability-based model? We speak about engagement. Engagement is when Dr. Nishant goes and shake hands with Madam Cassandra. But the accountability is that Madam Cassandra is coming here and shaking hand with Nishant. So that is the difference between engagement and accountability. Can we have that private sector accountability? Is it feasible? These are something. So Shadab, I have given you a short answer. Why yes? I'll give a shorter answer. No. No. Thank you.
All right, thank you for that short yes and short no. But yeah, what we understand is that there's a lot of things which we know, and there are still things which we don't know and we need to know. Moving forward, I think I can go to Dr. Upasana only. Dr. Upasana, as I said, has been our champion to advocate about TB. Dr. Upasana, question to you basically is about how you or any other mechanism has helped building partnerships or leveraging or engaging associations or network for TB. Are there some success stories there? And how can we scale these success stories if there are some success stories?
So first of all, we are lucky that we are having a hospital where we started TB screening, then we associate with union, and then we try to go for all those corporate which are on our panel for TB free workplaces. First thing is very much important that you need to make aware others that whatever, if they are going for something regarding TB, that is going to help them only. So what I am doing, because as everybody knows that I am on every takriban all chambers and councils. So whenever I have got a chance, I am keeping one session on TB to others who are not healthcare providers should understand the value of TB screening to find out. And if when there is somebody who is TB positive, they are supposed to give them some nutrition, medicine, and keep track. So this is the way we can tell others. Even I live in Golf Links and I organized a camp in my own campus. Shrija was there, and I have called Brian also, who was from USA. So we have done a total screening of all household help as well as whosoever was volunteered to come to. So such kind of things I am now doing with the factories. I am not limiting myself to only Ghaziabad. Now we are going to Noida, and right now there is a 100-day campaign from government side, and my hospital is sending for that our van and PCR and X-ray. So, and how we can engage, like it was, I think, brainchild of union only, that we should make a consortium of different states. So in Uttar Pradesh, I am chairing that consortium, and we have made every district there is a big hospital. I am involving owners, so they should understand, because reason behind this, if somebody like infectious disease doctor wants to do something, but finances are also involved in that. So top level is not ready. They say what we will get, why should we invest? So I just want to tell everyone, if you have this opportunity, that you can at least screen. I am talking to small hospitals also. If you can screen at least your own employees, if you can screen and tell us, and if you don't want to help them, we will help you. At least everybody should know how many TB patients are roaming around with us, and we can cure them. And I think we have done a great job, and everybody is quite aware about TB. And TB Mukt Bharat is now my face, and TB Mukt Bharat is also related. If I am going somewhere, everybody is saying, Madam is going to talk about TB all the time. So at least in every conference or in every public gathering, and in this, I just want to declare, because I was talking to Dr. Mattu, I met him. There is a female club, and I turned them into a NGO, and now they are providing us a van, TB Mukt Bharat Abhiyan, for they are providing me a van with all facility. I told them, don't waste your money all the time for your parties, do something for society. So this in April they are going to launch, and then I will talk to union how we are going further. Thank you.
Yeah, that's Dr. Upasana. That a kitty party has been converted into a into a Nikshevan, correct. So, and that's also the strength of multi-sectoral engagement. It's not only sector, each individual, each professional brings our own strength and our qualities, and that's how it becomes Jan Andolan. So probably I'll go to Dr. Sandeep first, and I come to the policy part later. So Dr. Sandeep Sharma, he is with the IOCL, has been there for a long time, very senior person in this sector. Sir, you have done a lot of CSR in TB. So I will not go into CSR part. Workplace is one thing, because unless we reach workers, we will not be able to cover the risk zone, the migrant workers, the vulnerable, unorganized sector workers. And you have the program which is foolproof. You have a policy on workplace intervention, you have full-fledged intervention, and you are covering each one. And doing this for everybody is not easy. So specifically, what are those new ideas you have employed to do this work for your, not only your value chain, but families and all employees? What are those 2-3 important things which we all need to learn and we can replicate?
Yeah, thank you, Shadab. So when this program was launched by our Honorable Prime Minister, that we should have TB Mukt India, Bharat, then our management decided that we should go for TB Mukt Indian oil workplaces. It was much before the directive which we got from the ministry, but we launched a program, TB Mukt Indian oil Parivar. And Indian Oil family, it is a big family, although we have 33,000 permanent employees and their dependents, that will be about 1,50,000. And the second, our family members are our contractual workers who are working with us. So they are more than 2.5 lakhs. And the third part of our family is the LPG delivery boys and the retail outlet attendants. So that is a huge population, because it is present across India, and they are more than 3.5 lakhs. So total, our Indian family belongs is totally, it is more than 7 lakh total population, which we decided we should go for TB screening for them. So we took the leverage of the technology, because without technology it is difficult to screen all our population. So what we started is from our own employees. So we developed a Indian Oil tele this TB Mukt Parivar app, and in that app was provided to all our employees and their dependents, and even to the the drivers who are driving the chauffeur driven vehicles for our senior officers. So all this screening was symptomatic. So the 7 symptoms which are there, so based on those symptoms, all employees they have and their dependent, they have to fill up and get themselves screened whether they are suffering from any of those symptoms. And based on that record, that whole exercise was done within I think 2.5 months. So once that phase 1 was over, uh, and there few 4 to 5 dependents and the housemaids and the drivers, they were found to having symptoms. So for them we got them investigated, we got them examined, and 2 of them, they were found to have tuberculosis, and they were started the treatment. Second was phase was for our contractual workers, means those who are working in the plants and those who are working in the townships also. So for them we have a online system of contractual labor management system, because all the contractors who are working with Indian Oil Corporation, they have got a system software in which they have to enter all the PF details and the particular personal entries of the contractual workers who are working with them. So in that only we made the provision of this symptomatic screening of the these contractual workers, and this in this way we covered about 250,000 contractual workers, and that took about 6 to 7 months. And the third phase was very tedious because it was spread across India, and all retail outlet attendants and LPG delivery boys, they needed to be screened. And for that we utilized that the another software which was for the retail outlet owners and the LPG this LPG dealers. So all these people, they are having a software in which they are connected with the Indian Oil, and in that they one LPG delivery dealer has got 50 to 60 people who are working for them. So all of them, they were screened, and this responsibility was given to the FPRs. So in all these phase 3, phase 1, phase 2 and phase 3, we identified the first person responsible who will get it ensured that people are entering the details correctly or not, and to facilitate them. So in this way we are still in the phase 3, it is not complete, but in this way we try to cover all our employees. And phase 1, we have already declared that now phase 1 is over, and it is tuberculosis free phase 1. And phase 2, some for some contractual worker dependents, some treatment is going on, and we are continuing with our awareness programs and other means to raise awareness amongst the population, how to take care of the TB patients, how to complete the treatment, and in case any nutrition is required, they are told that it is available with us, and for treatment they can go to the dot center, and they are all facilitated for completing their treatment. So in this way we covered this whole Indian Oil family to make it tuberculosis free.
Thank you, Dr. Sharma. So basically, I think your program has demonstrated that use of technology and commitment, because it requires commitment, right, is can make possible this kind of workforce which is so large and widespread. Still you can screen, test, and also provide treatment with job security, right?
So, as you rightly said, nothing can be done in a big organization without management commitment. So, when this program was launched, it was our chairman and the board of directors who launched this program. And chairman himself took the pledge, and this program was like live telecasted across the corporation. So, everyone along with the chairman, they took the pledge that we will make Indian Oil family tuberculosis free. And based on this example, now all the like locations, units, they are following this program because it is a management driven program. So that is important. Yes.
Sure. Thank you so much for sharing this success story of a large workplace intervention. And workplace intervention is critical because we have about 500 million workers in India. Unless we reach there, we will not be able to think about TB elimination. Thank you. And now, last but not the least, very, very important, Mr. Charudutta. Sir, question to you basically is about these are different models of intervention which we are doing in various sectors at a small level. And these innovations which you saw today in TB, lot of people, lot of new ideas. From policy and program perspective, are we moving in right direction in terms of encouraging innovation, adopting innovations, and spreading these new ideas for use at mass scale? Are we rightly placed with right commitment, with right policy directive, or there is something else which we need to think about?
Thank you, Sadhar. First of all, we are very enthused and motivated by the way CTD has organized this. This is unprecedented because you have people from all walks of life, and this is the basis of this intersectoral or multi-sectoral engagement that you're talking about. So, to answer your question, in short, yes, we are going in the right direction. Now, to justify that, why am I saying this? I'm saying this because look at the scale, and look at what we are doing with the program. Probably for the first time, it will not be an exaggeration, but probably for the first time, India's usage of technology for a public health scheme or a public health program like this has never happened. That's why we have these numbers. But giving life to these numbers is what's being done at the state or sub-state level. Why I'm saying this is because there are a few things as an economist and as a person who's engaged in policy work with the government. My first priority would be to see where are we heading and why are we doing this. We are doing this because not only because this is a morbidity, but this is a morbidity which affects the health, which affects the social well-being, which also affects the economy. So as a person who would always look for outcome-based inputs or outcome-based investments, this probably is one health program or one health initiative which gives one of the maximum outputs, x to about 33x, roughly, empirical. Now, if we are looking at this, and if you are saying that there will be about 90 crore more employment generated by 2030, and 70% or 80% of them would be gig workers, which means they'll be all moving around, and they are the youth. So, this program is probably one of the few public health programs which gives the maximum outcome or the maximum output for the throughput or for the input that we are giving to the program. Number one. So the budget that goes into TB programming is probably justified by the numbers and also justified by the way the program is being handled. Why am I saying this? I'm saying this because at a sub-district level or at a district level, by the way, I think if you're looking at Viksit Bharat, it's my firm belief that Viksit Bharat rests majorly on the shoulders of a district collector. That's the unit of growth or unit of economic growth for this country. So what is Viksit Bharat? we are looking at about 5x the increase in per capita GDP or per capita income and things like that. If today it's about 2,900 odd, we're looking at 10,000, 12,000. So we get into that league, which means that if we are doing a program which gives us 33x output or outcome, of course they're different, but in this context I'm using them in the same manner. If that is the output, and if this is the program where we are spending a lot of our resources, including our cadre of health workers who are there working in a sub district level, we are going in the right direction. What needs to be done? A lot needs to be done. A lot more needs to be done. For example, I mean, you have 4 minutes, so a lot to say, but quickly. One of the things that needs to be done is we have a regular programming or a regular review meeting with the district collectors leadership, which is called Disha, which was there. Different states have different names. I'm not getting into that, but what it essentially means is you're reviewing the district programs, evaluating them and giving them a direction, and also doing course corrections. So in Disha, TB should be an agenda item. How often does Disha meet? Depends on the leadership at the district level. And Disha also has the local MLA and the local, so people representatives are also there in this committee or this meeting. I'm not suggesting this to make it more bureaucratic. Please don't get me wrong here. I'm suggesting this because if we do this, the narrative for TB will come up. Because today we are in a different phase of aid or different phase of grant money or different phase of resource garnering, where we are looking at also private sector, we are looking at CSR. So what does it mean? It means that if this becomes a component of GDP, it gets that seriousness, that weightage. I'm not saying that there is no weightage or there's no seriousness now, but it needs to be improved. So then what happens is, if you make this a factor, a critical factor of the district GDP, then it gets into the item which is required for a solid policy initiative or a solid policy to action translation. Otherwise, it will remain a policy. Number one. Number two, in aspirational districts, I'm taking aspirational districts as an example because most of the aspirational districts, fortunately, unfortunately, have indigenous communities. Fortunately, unfortunately, they are the resource, paradise or the resource treasury. So you have all the bauxite mines, you have all the iron ore mines, you have all the nickel mines, you have all the cobalt mines in indigenous communities or the areas where indigenous communities live. So the CSR component has to be taken up more seriously. CSR is spiraling, fantastic. Dr. Nishant, to your point, we are zooming ahead. Really a very enthusiastic trend we see there, but it needs to be more formalized, more institutionalized, which means that whenever we have an invest state program, we should make it mandatory, or we should make it a kind of a addendum to the MOUs that we have, that if you have about 499 districts already as your focal districts, TB focal districts, out of 788 districts. Now that's quite a number. So if these are the focal districts, and if a particular plant or a particular unit is coming up in a district, mostly a greenfield industry coming up in a district, and today we don't have the catchment clause in a CSR, so they can do for the greater cause of the district, even if their plant is not there in that district, they can provide the CSR funds. And if that can be done, then that will give us additional resources. Number three, I'm not even going to DMF. DMF is a resource which is already available. Now, if DMF can be utilized for strengthening the PHC, the CHCs have been decentralized. Now the PHCs are taking care of them. Now you have Bharta Bahaks who are incentivized. Now we have in some states, I'm talking about Koraput. Koraput has done tremendously well in terms of 100 days Abhiyan, almost 94-95% notification, and they have also done well in terms of decentralization. So can we have more doctors? Because absenteeism of doctors is for various reasons, for infrastructure reasons, for other reasons. logistic reasons, difficult terrains. So can we also have more resources there? Leading to this is our technology. Now, having somebody talk to us about TNGS without realizing, I'll give you one concrete example. Whatever I'm saying is directly from the field or from the secretariat. Now, in a particular central India state, the health secretary, so there was a presentation by TNGS, NGS people, and the health secretary asked, so now I have NAT, my expense is per sample X. You are telling me it's 10X. So you're talking about only XDR cases. Do you mean to say that by spending X, I cannot handle XDR cases, which I have been doing so far? So what I'm trying to say is that India now is at a different level and a different dynamics. Whoever is coming to the point that Dr. Paul today made very, very, relevantly and very articulately, that mere showing of new technology or mere showing of innovation is one part of the story. Adaptation of that innovation to solve my problem in my state, in my district, in my village is another part of the story. So if you're coming to India and if you're talking about multi-sectoral involvement, convergence, intersectoral linkages, I have to work with Rural Development Ministry. I have to work with National Rural Livelihoods Mission. You are already working with Panchayati Raj. If I have to do with SSGs and FPOs, they better afford this. And we better afford this as a public health system. I'll pause here. You can go on. Thanks.
Thank you so much, sir. I think lot of information and possibilities and encouragement for all of us in terms of moving forward. And it seems from this discussion that we are in the right direction. And obviously, there are lot more things to do. Since there are a lot of things to discuss, but it's the end of the day. It was a very, very long day. I don't know if there is any possibility of the question answer, but maybe in the interest of time and considering that everybody has to leave, I would like to thank each of the panelists for making this discussion very, very interesting and insightful. And now again, this reminds that a issue like of TB, which is beyond medical area, requires expertise and resources and sectoral approach and departmental approach. Everybody has a role, and we need to find those ways of connecting those people with the program, those sectors with the program. And these initial successes which we have got need to be built and strengthened further. So thank you so much, everyone, and thank you the audience for staying with us for this very, very last session. With this, I think we can conclude. Thank you so very much.
Thank you, sir.
Thank you, Shadab, for moderating the session so well, and thank you all the panelists and the audience. So I request Shadab, if you please could greet all the panelists with a small memento.
That's an honor, right?
Yeah.
So any order? Can we start from here, right?
Yeah, please. Yeah, please. Thank you. With a big round of applause, please. Yeah. Thank you.
That is the true spirit of MSc, not starting with the government.
Leverage.
I will stick to my word. I'll take it last. Thank you for such nice panelists with this kind of discussion. But we need to